Here is part 3 of chapter 8, surgical procedures. Continuing on with a couple of the more interesting surgical processes we may engage in. This week we start off with ophthalmic procedures. I don't know if your practice does a lot of ophthalmic procedures or not. Almost all practices have to do them to a limited degree, but what many, what kinds, and what depth varies tremendously. There are a lot of, as you would expect, specialized instruments, and you need to refresh yourself with those. Go through the book, look at the slides, pictures, figure out which one's which, and be able to identify it. There's things that we use like half-curved tissue forceps, Chalazon forceps, Jaeger eye plates, tendinotomy scissors, needle holders. Lots of good instruments that are involved in specialized ophthalmic procedures. And here's the half-curved tissue forceps, and so on. There's a Jaeger lid plate down below. Chalazon forceps. The ends may be circular or oval with round, smooth edges. Various aspects of those particular instruments. Tendinotomy scissors on the left, and then finally on the right our Castro Viejo needle holder with a catch. And just on a personal note, I really like Castro Viejo needle holders. I'll use those on small animals for just general needle holders. They really work nice, but they are specialized for ophthalmic procedures because of their size and the way they work. But they're really just generally nice needle holders. Don't work well in Great Danes, but everybody else, pretty good. Common things you'll see that are easily surgically corrected. Number one is the entropion. And if you've been in a practice very long, sooner or later you're going to see these puppies that come in with these matty eyes, and they're obviously, playing, showing signs of entropion. Entropion refers to a rolling in of the eyelid, upper lid, lower lid, or both lids. Usually in my experience it's been mostly lower, but you can see them everywhere. May involve any region of the eyelid, the medial aspect, the lateral aspect, or the entire lid. Can roll in up against that cornea. Surgery alleviates ocular irritation caused by the eyelid or by facial hairs adjacent to it. Those hairs just rub on the cornea and rub on the cornea and rub on the cornea, and that gets to be a really painful, unhappy situation. The clinical signs are going to be lacrimation, blepharospasm, photophobia, endophthalmitis, conjunctivitis, keratitis, self-trauma, decreased vision, developmental entropion, spastic entropion. There's all kinds of things that are going to be seen. Basically, you can look at that eyelid and just see it's rolled in and rubbing up against the cornea, and there is gunk and stuff coming out, and it's extremely painful. If you've ever had a corneal ulcer, you'll know those things hurt. There's, again, a couple of surgical options. There's eyelid tacking, the Holt-Celsius procedure. You can go through those in your book. And if done properly and well, and these are not that difficult, they can almost instantly alleviate the problem. Once surgery is over, there will, of course, be a little bit of tissue swelling. The eye is a area that swells easily, and it will have to be carefully monitored. Warm compresses will help. Suture removal in 10 to 14 days. Topical ophthalmic antibiotics. E-collars on a lot of these guys really do help. Can really make a big difference in getting the healing speeded up without secondary trauma. These guys go home. They do extremely well, especially if you have owners that can do a good job of medicating the eye at home, putting in their ophthalmic antibiotics. Once you get those eyelids and the eyelashes from not rubbing up against the cornea, those corneas will heal very quickly. They just really resolve themselves. They're very happy not to have to put up with that anymore. Ever so often you can see some of these corneal ulcerations that get really bad. I've heard stories of them eventually just rupturing and the eye's lost. But if you can get to these pretty quick, good, happy resolution. There are significant number of eyelid masses of neoplasias Incidents and differentials, dogs, usually benign. Meibomian glands, those are not a big deal. Cats, bad story. You see a lot of squamous cell carcinomas in cats. And if those get going, they're really nasty, not good. You'll see the signs, you'll see the obvious tumors, you'll see the irritation, how angry it looks. You really need biopsies on these things or cytologies. You need to know exactly what you're dealing with before you start doing anything silly like cutting on it. Indications for surgery. I mean, there are alternatives to surgery, but if it gets going very long, if it's something that really needs to come out, it will have to be cut. If the mass is too large, if it is truly malignant, if it's causing irritation, say against the cornea or the conjunctiva, if the patient is traumatizing, a lot of these things apparently are a tremendous bother to the patient. So they will rub on it, rub on it, rub on it, and their rubbing is just about as bad as the mass. Oh, cherry eyes. Oh, I love it. Protrusion or prolapse of the gland of the third eye, still commonly known as cherry eyes. The nictitating membrane, if you're not familiar with that, you need to review your anatomy a little bit. Protects the eyeball, removes dirt. You've got your Colville and Bassett text. Look that up. Look up nictitating membrane in the eye. It is the most common disorder of the third eyelid. Results of a weakness in connective tissue. There are some controversies about what does or doesn't cause it. Almost always everybody admits it is a weakness in connective tissue. Becomes enlarged, inflamed due to chronic exposure. That the gland just kind of flops out, hangs out there, starts to become red and inflamed, has a cherry-like appearance, which is how I got the name cherry eye, and just continues to get worse and worse. Abrasions and drying exposed gland may result in secondary inflammation, swelling, just a big mess. Cherry eye, big mess. That sounds like a good topic for a test question. Clinical signs, you're going to see ocular discharge, conjunctivitis. This pink swollen mass is just kind of hanging out of the medial canthus of the eye. Decreased tear production. The eye will get dry. You can start to develop some conjunctivitis sicca. There are several ways to fix these. At one point, it was recommended just to remove the gland itself, but that is not really, unless there's some deep, profound underlying cause like it's become cancerous, not a desirable situation anymore. Excuse me. Possible reoccurrence resulting in one or more repeated surgical attacks using different techniques. So a lot of people will start very conservative on these, and if that didn't fix it, then they move to something else. And if that didn't fix it, then they move to something else. And considering what this gland does, its importance to the health of the eye, its importance to keeping the eye moist and protected, if we can preserve the gland and if we can make sure it is as functional as possible, we all come out ahead, especially the patient. The Morgan pocket technique for repair of a prolapsed gland of the third eyelid. This method involves securing the third eyelid gland into a conjunctival pocket formed in the margins of the third eyelid. You basically take it and just oversew it, just kind of make a little pocket for it. This is probably one of the earliest, easiest, quickest ways to do this. As you can imagine, if you're going to do sequential surgeries to try to correct this, there's going to be a lot of anesthesia involved. And so in a lot of these times, it's very young animals where we see this, the 12, 14-month-olds that start showing cherry eyes. So, your pediatric, anesthesia is going to come in handy. This method of suturing prevents corneal irritation from the suture knots. You have to bury those knots and kind of pull them back out, and it works fine. This resolves a very significant number. Moving right along, the book jumps into orthopedic procedures and fractures. Now, as we go through the surgeries, it essentially, in a lot of ways, the further along we go, the less likely you are to see some of these. A significant number of students work in practices that do not do any orthopedic procedures. Orthopedics is a specialty, quite a technical specialty. And I'll be the first to admit that I make a lot of jokes about the arthropods and Yeah, it's just kind of, sterile carpentry and all that kind of stuff. But in truth, we do see a lot of orthopedic problems. And people that are really good at orthopedics have my deepest respect. I'll tell you real quick, because they have a technique and art I just don't have. Um, so we're going to deal with some. If you work in a practice that does orthopedics, you'll see a lot of this. If you're working in a practice that doesn't do orthopedics, pay close attention because this shows up on the VTNE a lot. Your responsibilities as a technician is to understand fracture management and repair, to triage these guys when they come in, evaluate, refer, prepare the patient for orthopedic surgery, etc. Work in an emergency clinic. I'm blessed to have in almost all cases, some very excellent technicians. In fact, a couple of them graduates of this program, and they are really good at triaging. That makes a world of difference to me. You've got an orthopedic problem. In one room, you've got a dog that's been run over by a car and his tarsal joint is in a million pieces. In the next room, you've got a poodle that's been limping for the last 12 years because nobody will go ahead and repair his craniocruciate ligament. And so, who's going to get the attention first? I mean, that triage is absolutely important, especially on a busy night in an emergency clinic. Coaptation, good word to know, is the application of an external appliance such as a splint or a cast. There are types of bandages that we will use for fractures. Robert Jones, modified Robert Jones, Emers, Spicas, Velpos. Almost everybody these days uses Robert Jones or modified Robert Jones. You don't see many Emers, Spicas, or Velpos. Preoperative considerations include the size, general weight, temperament, age, owner compliance is crucial. The old saying that to repair a fracture requires a great surgeon, to screw it up requires an average owner. So if owners do not work and play well after the surgery, you can see some horrible, horrible things when they don't pay attention with casts and splints and pins and plates and just stuff. Fracture assessment, be sure to know your fracture assessments. These are good basic terminology questions you'll see on the VTNE. Fractures can be classified by the following factors: bone location, open or closed, location of the fracture, the type of the fracture, whether it is reducible or non-reducible. Know your terms. Radiograph should always be taken to assess a fracture. You don't have x-ray vision. You're not Superman. You're not Supergirl. You have to actually use the x-ray to find out what's going on with that bone. Open fracture types, a grade 1 is there's a small puncture in the skin near the fracture location, just barely visible. Grade 2, there's a larger puncture or tear in the skin near the fracture with evident soft tissue damage. You can see it's torn up some muscle and stuff. Grade 3, large tears, loss of skin at the area of impact, plus extensive soft tissue damage and bone fragmentation. And you look at these and you just kind of go, oh my Lord, oh my Lord, oh my Lord. That's terrible. These can be pretty disgusting. Be sure to know your bone anatomy. If you don't have time, go back through it. You probably are picking this up in some other classes, but if you're not really familiar with the basic parts of the bone, the epiphysis, the diaphysis, the medullary cavities, endosteum, periosteum, metaphysis, articular surfaces, physes, or epiphyses, depending on how you want to classify them. Know your bone anatomy. Okay, by the time you get ready for the VTNE, and that's coming a ways down the line, you're going to need to know bone anatomy because they ask bone to understand fractures. You have to understand the bone. A lot of concept. Bone plates, proximal and let's see what it says. Area close to the body or point of origin. So your book goes through describing basic terminology, and that's about all this is. Okay, you need to know midshaft, proximal, distal, medial, lateral. You should have gotten all that stuff back in medical terminology. Oh, types of fractures. Number 1, transverse. Number 2, oblique. Number 3, spiral. I hate those. Number 4, comminuted. We got a piece of bone just kind of hanging in there all by itself. Number 5, comminuted, non-reducible. So, you in 4, you can kind of put those pieces together and hold them. And 5, you got too many pieces to do that. I mean, you just got bone fragments everywhere, okay? And there's numerous fragments. A lot of times they're crushed and they're just nasty. You really don't want to see 5s. If you got to see a fracture, 1s, 2s, those are nice. 3, 4s you can handle. 5s, man, that's a one-way trip to a referral to a good orthopedist. Oh, they talk about Salter-Harris fractures. Type 1 fracture runs through the epiphysis, the physis or the epiphysis. Type 2 fracture runs through the metaphysis and physis. Type 3 fracture runs through the physis and epiphysis. Type 4 fracture runs through the metaphysis, physis, and epiphysis. And type 5 fracture is crushing injury to the physis and may not always be detected initially by radiograph. You just kind of smashed everything together. So if you don't see big pieces, you may think there's nothing wrong, but there most certainly is. Spend a little time knowing your definitions of Salter-Harris fractures because we will see these particularly in puppies. These are Y and T fractures through the distal, in this case, the distal epiphysis. You can see why it's a Y fracture, you can see why it's a T fracture, and they are a mess. Trying to get all those together and preserve the integrity of the joint isn't always easy. Surgical options for fracture repair. Well, we can do internal fixation. This is rigid under the skin and muscle directly in or on the bone or intermedullary cavity. We have to go in and we have to fix it. External fixation is applied through the skin and muscle of the bone to the bone and the medullary cavity. In other words, we go in, but we don't make a surgical big long incision to have to fix it. And each one has its advantages and disadvantages. Broad spectrum antibiotic, bacterial, antimicrobial, and antifungal scrub and final preparation before surgery. This might also be a big good time to tell you, if you're not familiar with it, bone fractures hurt. Breaking a bone hurts. I've had broken bones. You may have had broken bones too. They hurt. So good analgesic care from as soon as you can get it started is in that patient's best interest. A lot of people say, if you don't let them hurt, well, they're going to run around on it. They're going to make it worse, yada, yada. No. What's going to happen is if you don't provide good analgesia from as soon time as possible, that is going to actually delay healing more than leaving it alone. Pain causes inflammation, causes untoward responses in the body. Pain is just generally bad for healing, period. This applies to orthopedics as well. Examples of internal fixation, and if you work in a practice, you may have seen bone plates. This is different types of bone plates where we put the plate up against the two edges, screws through to hold it together. Interlocking nails can be used to go through in various places to stabilize the bone. This one running from proximal to distal as well as through the body of the bone itself. Interlocking nails work real well. And that's what it looks like when you get finished. You got a whole bunch of nails and screws in there. And then you may throw in some wires and some other stuff. Interlocking nails and instruments. This is what the kit looks like. You buy these as a kit. You've got screwdrivers and pins and plates and the whole kit that you need to do this. It's not easy to do. It takes a lot of time and does take some art. It takes some skill. You can't practice this if you're bad at it and get good at it. If you're good at it and you practice, you'll be really good at it. Intermedullary pins, IM pins, sometimes referred to as Steinman pins. These just go down the shaft of the bone, hold it together. This probably in a lot of ways is one of the more common of the techniques we use. It usually works pretty well. Intermedullary pins, there down at the bottoms. There's a Jacob's chuck, which is probably the most common one we're going to use. There are drills. There are all kinds of ways to do this. Like really good carpenters, orthopedists really like really good instruments, and I don't blame them. There's a lot we can do with these guys to put these bones back together, really have good resolution of fractures, and it takes good equipment to do it. Orthopedic wires, it's not uncommon to wire some stuff together. Wires are, commonly used. There's a full cerclage wire. Cerclage, the French word meaning to encircle. I love that word, cerclage. For fracture stabilization, then there's the hemicerclage wire application, where we just go around part of it. Cerclage on the left, hemicerclage on the right. And if I can find a way to say cerclage one more time, I will love it. If you can say words that sound French, it makes you sound smarter, more sophisticated, more worldly, as I cerclage the world. All right, moving along. Internal fixation. If we're going to do internal fixation, there's a lot of post-operative care with internal fixations. They really need to be strictly confined for 6 to 8 weeks, and the minimal amount of exercise to keep those bones in the same position. Suture removal and recheck in 10 to 14 days. Follow-up radiographs every 4 to 6 weeks, sometimes more, sometimes less, depending on the preference of the surgeon, to ensure that we're keeping good alignment on the bone and everything is going well. Monitor younger animals more closely because they can screw things up faster than older animals. And the bones, because they're far more active at that point, you have far more osteoblast building bone, then you're going to find that if something does go wrong, it can really cause a problem in a hurry. External fixation, cast splints, SK fixation, Kirschner Emer fixation, ring fixation. There's several different types of external fixations. I mean, just putting a cast on it is an external fixation. Putting a splint on it is a type of external fixation. And some of these guys, the old joke about young animals is if you can keep the two ends of the bone in the same room for 2 weeks, they'll heal. So we get away with a lot of casts and splints. Don't always, but sometimes we do, and it really is, it's obviously easier on the animal and the owners, and a lot of times even us, if we can just put a good cast on it or a good splint on it, get good resolution of the fracture, and move on, not have to do anything through the bone itself. There's a KE set, Kirschner Emer bars, clamps, and wrench for adjusting of clamps used for external fixations. Got some pictures of that coming up. There is an SK set. This is SK rods, clamps, and a wrench for adjustment of the clamps used for external fixation. Here is a ring fixator. No, this is not a ring fixator. I think that's mislabeled. This is external fixation. This is one of the pins through. As you see, we put pins through the bone, then we put it in alignment. We put the bars, clamp that down, and there we go. I'll show you a picture of a ring fixator next. That's just a good external fixation repair. And that works great. As you can see, there's no big incision. Mostly through the skin. There's much less chance of the secondary infection because we haven't gotten in there. These guys can work really, really well. Here's a ring fixator set, and these go around and then from the leg, and then you put the pins through and hold it, and then they go through the various parts of the rings. I don't know if we have, let's see if we have a picture coming up. If we don't, you can look up. I believe we have one in the text, and you can. These work really. There's all kinds of these. There's a Lizarods, there's some others, and ring fixator sets work well. It's just as a personal point, I've generally found about a third of the orthopedic surgeons I know really like external fixation. About a third really like internal fixation, and about a third are, fine with either one depending on the particular case. There's no good or bad with that. We do what we're good at. We do with what works for us, and so if you're working in a practice that does orthopedics, you may see a lot of opens, you may see a lot of closed, you may see combinations of both. External fixation, post-operative care, weekly or bi-weekly appointments for fixator adjustments, clean the pin tracks, bandage changes, make sure that all those little bars and screws and things are working well. It is inappropriate for pelvis or pelvic joints, just can't get it in alignment and do well. We need radiographs about every 4 weeks until the fixator is removed. And again, that will depend a lot on the healing, the age of the animal, the type of fracture. That may come off pretty quick. That may stay on for quite a while. And we do need activity should be restricted for the first 4 weeks so that the bloody callus can evolve into the bony callus, and the bony callus can then reestablish proper periosteal activity. We just need to get that bone kind of steady before we start taking things off or letting them run around. Considerations with casts and splints. And if you've been in practice for a long, you're going to know there's lots of considerations with practice and splints. You need the anesthesia to relax the animal. They just don't like you setting bones while they hold them down. Splints are best for injuries distal to the elbow and the stifle, further down the leg. Sedation for cast or splint changes. If you have to take it off and replace it, and it should be done periodically, then yeah, you're going to have to sedate them. Cast checked for at least every 1 to 2 weeks, and any swelling of the toes, malorder should be addressed immediately. Okay, don't wait on that. If that's 2 o'clock in the morning, do it. Potential complications can be many, including infections. It gets nasty. You can have tissue ischemia. External fixation is great if it goes well. If there's a problem, not so much. Amputations, we do see amputations, and amputations are indicated. Common indications would include severe soft tissue damage, irreparable fractures, neurological injuries, neoplasia, ischemic necrosis, unmanageable arthritis, severe genital conformities. A lot of things can go wrong. The dog that's in the room that just got his tarsal joint completely shattered and there's nothing left from about the tuber calcanei down on the leg, the metatarsals are completely fractured. Those guys are candidates for amputations. Foreleg, you can have you usually do it at disarticulation of the shoulder joint or removal of the scapula. I don't usually remove the scapula unless there's a specific indication. Hind limbs, midshaft femoral amputation or disarticulation of the coxofemoral joint. I can do either one depending on what's going on. And a lot of people really get all upset about, doing amputations. Amputations not that bad, 3-legged dogs, you will be amazed how fast they can get around, okay? And I guarantee if you work in a practice, there's somebody that's got a 3-legged dog or a 3-legged cat, and they've got to call them tripod, and those guys really do remarkably well. They do much better amputated than with a constant ongoing source of pain and irritation. All techniques involve severing the muscles at their origins. Insertions are directly through the muscle belly. It has to be done neatly. Major nerves are isolated, injected with local anesthetic before transection. And there's several things you can use. I'm a bupivacaine fan. Pain management on these guys is crucial. Critical. You really have to keep them on some heavy-duty drugs a lot of times, and occasionally what you'll do is you'll find some of these guys that are just in terrible pain from whatever's going on, and just getting it off and is in itself a relief. Opioids, initially NSAIDs, transdermal fentanyl patches, and often administered post-operative. I've had people tell me that patches are not particularly good for this. I've had people tell me fentanyl patches are good for this. I tend to rely more on heavy-duty opioids with a general transition towards NSAIDs as we go, but that's just me. Personal preference. Some people order fish. Some people order steak. Some people order vegetables. The other one we're going to see, I tell you, a lot of, and if you work in veterinary practice, you're going to see lots of cranial-crucial ligament problems. Anterior crucial ligament, cranial crucial ligament, depending on how we unit. In veterinary medicine, we tend to call it cranial. In human, you often hear ACL far more, especially in relation to football players and athletes and that kind of stuff. By far the most common cause of hind limb lameness in dogs, no question about that. And there are several different ways that we can do this. You can palpate. There's a tibial compression test. The cranial drawer test or anterior drawer test is the classic way to diagnose these. And if you get a positive cranial drawer test, you've got a ruptured cranial ligament. No ifs, ands, or buts. CCL repairs, orientation of the cruciate ligaments and the menisci. Again, we get into our orthopedic anatomy and physiology. If you're not familiar with that, spend a little time, but it's really pretty easy because you've got a meniscus between the femur and the tibia, and you've got a lateral and a medial menisci. There is an intermeniscal ligament, and then you have the two cruciate ligaments. There is a cranial, and then there is a caudal, or anterior and posterior. And that's what those X-crossing ligaments are really what pretty much holds that poor old knee together. Knees are not good joints, okay? If you give design to joints, probably the poorest grade you would give on design is the knee, especially for people where we tend to walk upright and we don't walk on our our arms to help support it. This is the cranial drawer test. To examine for cranial cruciate injury, place the thumb of one hand over the lateral fibula of the index finger over the patella. Stabilize the femur with this hand. Place the thumb of the opposite hand caudal to the fibular head, and with the index finger on the tibial tuberosity, with the stifle flexed and then extended, attempt to move the tibia cranially and distally to the femur. So all you're doing is you stabilize the femur, hold it real tight, then get the tibia and try to move the tibia back and forth. That tibia should not move back and forth, okay? If you're applying a normal amount of pressure, it ain't going anywhere. If it starts sliding back and forth like a drawer sliding in and out of a cabinet, you have an anterior cruciate ligament severance. It is gone. So that's a drawer test because it acts like you're sliding a drawer in and out of a chest. There are special instruments often associated with CCL repairs, cruciate repair systems, Holman retractors, all kinds of things. And so depending on if your practice does or doesn't do cranial cruciate repairs, and if they do them, how they do them will also dictate what instruments you're going to have. In most cases, all the orthopedic stuff for a particular surgery like a CCL repair is in a separate kit. It's sterilized, it's sitting on the shelf, it's ready to go. Proper patient positioning for these guys is essential, mostly because you have to be able to really scrub this. You're going into joints, you're going into bones. You do not want to produce infection in there, and you have to be meticulous, absolutely meticulous about how you scrub these things. Orthopedic procedures under CCL, there is the intracapsular form of repair where we actually go into the capsule and we replace or reconstruct the ligament itself. There is the extracapsular. This case, we stay out of the capsule, extracapsular, and sutures are placed outside the stifle joint. And either way, both rely on recreation of passive constraints. The drawer's not going to slide anymore. Cranial tibial thrust rupture causes the tibia to slide forward and the femur to fall back, creating a shear force, which is never good. So know what a cranial tibial thrust is. Here's an example of an extracapsular reconstruction using a heavy, non-absorbable suture. The suture passes through the deep fascia surrounding the fibula and through a pre-drill hole in the tibial crest. See a little hole down there in the tibial crest. Tying or crimping of the suture eliminates the cranial drawer sign. So it's just holding it together. When you try to push that tibia forward, it can't go forward, so that takes care of it. You're essentially creating an artificial ligament. If different surgeons have different techniques, okay, there's all kinds of techniques to do these. And what's going to work well is going to be what your surgeon thinks is the most indicated and how it's performed. For postoperative considerations, you need a soft bandage for the first 48 hours at least. Recheck in 14 days. Take out your sutures when it's ready. Exercise restriction. They can have short leash walks for at least 6 weeks. A little bit of exercise for these guys in almost all cases is a good thing. Okay, you know the dogs, they get on the end of a leash and it's like they're trying to pull the sled across the tundra. Those are not real good. But for the little dogs, and this is almost always in little dogs, you're going to find a nice moderate walk around the block is going to be good for them. Also helps keep some weight gain down. Pain management will be essential. And then rehabilitation programs, I cannot stress enough. If you work in an area where you have the good fortune, in most large cities, you'll have the good fortune to find canine veterinary rehabilitation facilities. These do work wonders. Okay, you can fix the knee, but that does not necessarily mean it's going to work the way it should. Rehabilitation programs will provide that. Put a star beside rehabilitation programs. And that concludes part 3. And there's another picture of a really cool surgery room. This one's got, a lot of, they've got trays open, monitors on the wall. I don't see a C-arm in there anywhere, but they got really cool lights and all kinds of things. I will tell you, and this, I'll finish up with this story. We had our site visit from CVTEA not too long ago. And one of the things that we were criticized for, heavily criticized for, is in a student's surgery video, they had a stool in the surgery room that had a cloth cover. Cloth covers cannot be sanitized. You'll note stools in this, I see 1, 2, 3, are a plastic or an impervious type of material. So if you're going to use a stool in your video, in your surgery room, either get it the heck out of there so nobody sees it, or cover it with something that you can sterilize. Heck, put a drape on it, and that will work. But if you have a stool with a cloth seat now in your video for surgery, it will not pass. And you can thank the fine folks at CVTEA for that. Sometimes we need to solve problems and not just create them. And I do see an anesthesia machine way back there in the back. 2 vaporizers, looks like a good unit. No monitors attached to the machine, but I imagine all that information is on a board somewhere. All right, that concludes this part of Chapter 8.